Okay, good. So let's get started. Start of a new year. Wishing everyone a happy new year, and I'm pleased to say we have a nice, simple topic. Working with syntonic resistance, possibly one of the hardest client groups to work with. Um, when I think about my early years as a clinician, I think broadly speaking, I felt like there were a category of clients who did quite well with talk therapy, and I wasn't necessarily being that precise around what my outcomes were, but I felt like people could get benefit. Then there was another group of people, even though I couldn't necessarily quantify the characteristics of who they were, um, based upon the knowledge or training I had at that time. But I felt like, roughly speaking, they weren't benefiting from therapy, and it almost felt like they didn't really want to be there. Um, they weren't really motivated to make changes. Part of that was certainly my own countertransference, but there was a category of patients I didn't know how to understand why we weren't making changes in therapy. I think that started to change for me personally when I was first introduced to first videotapes of talk therapy. It was relatively scarce in my clinical training. It happened to be that my opportunity to see videotapes and actual therapy in progress was through the ISTDP community. I don't think that's a coincidence, but put the two together, I could start to see actual therapy and how therapy was benefiting clients and how things were changing, but also why things weren't changing at times. Because the video's right there in front of you, what's happening. You can't hide a positive treatment process the same way you can't hide one which is running into problems. The second element of that over the years, which has become helpful for me in terms of understanding resistance or the concept of why people struggle to engage with a therapeutic process, assuming that the therapist themselves is doing a good enough job in trying to engage and understand the client. Well, that's where ISTDP offers a metapsychology, which we're going to be talking about over these next 6 months to help conceptualize and understand why people struggle in talk therapy and what the processes might be to help work with those, to help people come unstuck and to engage better in therapy. And in terms of today, the specific goals for this first part, because this is a 6-part course, so we're going to be changing the different sort of competencies we expect to develop over the course of the 6 months and looking to accumulate more gains as we go through. But today we're going to focus more on how we conceptualize and how we can recognize this idea of a syntonic resistance, defenses that manifest in the therapy room, which the client holds on to consciously or unconsciously. They don't see it as enough of a problem to want to change. It's part of who they are. And those processes that you're talking about are the exact processes which we think are potentially affecting the ability to collaborate, to make changes. And then we're going to narrow in on talking about the standard format of ISTDP. So that's the format of ISTDP, which is for people with good anxiety tolerance. We see no signs of cognitive perceptual disruption, no signs of dissociative type phenomena. We don't need to take a more graded approach, a gradual approach where we're trying to regulate their anxiety and titrate it to avoid them becoming flooded. We don't need to do that in the standard format. So we're going to focus on the use of the standard format today, and we're going to cover some slides today just to help people think about that. And 3 key principles around working with the resistant client using the standard format. First one's going to be the use of what we call pressure in ISTDP to tilt the manifestations of defenses into the here and now of the therapy room. So we actually welcome those resistances. So they come in the room into what we call the transference, the here and now of the therapeutic relationship, so we can start to work with them. The second's going to be the principle around once the defenses are actually in the room, they're occurring and forming something of a barrier between the attempts to collaborate with the client. Then when we start to help them see these defenses, this is where we start to see that rather than being dystonic, i.e. the client has good insight about them, they see them as a problem. They see them as interrupting their ability to get satisfaction from life. They see it as something they want to change. Rather than that, syntonic defenses or syntonic resistance are those, as I described before, those that the client on some level wants to hold on to. They see them as serving a purpose and that they need to hold on to them. So then the concept of how we need to use identification and clarification first to help a person understand a more unconscious process, to help them develop insight about their defenses, and then to start to incorporate a more powerful intervention, the concept of challenge, whereby once the person understands their defenses better, in concert with them, we can start to ask them to challenge them to relinquish those behaviors in the room. We can start to point out the negative, destructive impacts they can have. And that can actually be positive, not experienced as critical and diminishing of the client's efforts. Then the third principle would be if we can work through these transitions of slowly bringing the resistance into the room, helping the person begin to turn against it. With this syntonic resistance, this isn't enough for the person to start to open up more with us about the key issues in their life. They open up some, but they still hold on to a need to detach and need to keep things to themselves. And this is what we talk about as the concept of high rise, whereby emotions are high, but also in the highly resistant patients, resistances are still entrenched. So we don't expect to see big insights. We don't expect to see big connections or links to the central dynamic conflicts the person has, because there's still a high level of resistance around. So this is where we're going to talk about the concept of, in ISTDP terms, the head-on collision, which is a broad category of intervention akin to challenge, where we help a person really turn against the unconscious patterns of locking down and shutting people out. So these are going to be some of the key objectives from today, and we're going to build upon these over the rest of the course. We've got a group of PhD candidates in clinical psychology from across Canada with us today. So I'd like to welcome you first and foremost. I know a lot of you are very new to dynamic work and certainly ISTDP. So what I'd say to you is hold on to your hats. I don't know how much access you've had to therapy tape, but I remember my own experiences. It can be quite thrilling to actually see a process unfolding in front of your eyes, and also quite different to typical graduate training in certain therapeutic modalities. So some of this is going to feel quite new. That's why it's a longitudinal course over 6 months. So hang in there. I'll be sending out information between sessions to assist you, and please ask questions. There are no bad questions here. We welcome them. To colleagues who have more experience, are more familiar with ISTDP and other therapeutic modalities more generally, what I'm going to encourage you to do is to ask yourself and be curious around questioning what you think you already know, the assumptions you have around how to practice and why things are going well or not going well in your practice. Be open to be curious about those and to challenge your preconceptions and conceptions. But I'd also encourage you to challenge me. Challenge me with questions, invitations to expand upon what I'm talking about, to better explain or more thoroughly explain what I'm doing in my tapes, and help bring out the best in me by being able to talk about what we're doing. I'd also say to all of us, let's be humble. We know we don't have a 100% success rate in psychotherapy, far from it. There's so much we can learn here. So let's be humble and let's not be harsh and critical on ourselves. We're all here to learn and we're all still learning. So let's do that as a group and invite you to use the chat function as we go through to ask different questions. And I'll do my best to respond to those as we go through. And we're going to have regular opportunities where I'm going to pause the tape to invite discussions. Okay, so let's get started. Some basic metapsychology around principles within intensive short-term dynamic psychotherapy. Inherent in the ISTDP model is the impact that early attachment experiences and specifically adverse attachment experiences have in the development of psychopathology and challenges around mental health issues. The importance of bonding and positive bonding experiences with primary caregivers, but when there's some interruption in that attachment relationship, we can define this as pain and trauma. So pain and trauma can manifest typically on an attachment perspective with a range of complex feelings being triggered towards our primary caregivers for failing advertently or inadvertently to meet one's attachment needs. In the highly resistant patient, you will see reactive rage towards the primary caregiver, strong negative feelings triggered inside of one towards the primary caregivers who've, again, advertently or inadvertently hurt them, but also due to the basic desire for attachment and love at the heart, guilt about this rage, painful guilt about having such intense negative feelings towards a loved one. And based upon the trauma that's occurred and the adversity in a person's life, multiple waves of sadness or grief about what has been lost, both for the client themselves, but also for their loved ones, and also the intergenerational pain and suffering, which is very common within family structures. So then how does this lead to trauma? Well, being exposed to adversity in itself isn't by itself a definitively going to mean a person develops severe mental health issues. Obviously, if people are resilient and people have positive experiences after the trauma where a person can make sense of their emotions, they can roll through the trauma and they can become more resilient and they can do okay in life. But what happens when these feelings, these complex feelings, the person doesn't have an attachment figure, an adult around to help them make sense of all these feelings, then they inadvertently internalize punitive messages around whether their needs, whether their feelings, whether their attachment needs are actually important. And we could call this the superego, the conscience in psychoanalytic terms, and how this develops a punitive thread when advertently or inadvertently the primary caregivers don't provide that space to make these feelings safe to look at. So the person develops an internal working model which says you shouldn't open up. You shouldn't have these feelings. It's wrong to have these feelings. It's selfish to have these feelings. You're going to hurt people if you have these feelings. You're going to hurt the people you love. So the person develops coping strategies. So they don't have to have this conflict between these feelings inside of them, but also they're developing conscience, they're developing personality, which is telling them how they should or shouldn't be. This is what we talk about with defenses. People develop defenses to mitigate the pressure between all of these complex emotions and the superego. And we're going to talk over the next 6 months about different categories of defense. We're not going to go into those in a great detail at all today, but we will do over the next few sessions. So we see on the outside major resistances, character defenses, and resistance against emotional closeness to reduce a person's anxiety about actually having to be consciously aware and think about the emotional burdens they carry around with them. So how does this manifest then with this concept of resistance in the therapy room? How can we understand why, when we sit with a client and we invite them to tell us about their presenting problems, we show interest that we want to get to know them, that we want to help them, that we hope they want to help themselves, and we think that's possible? Well, based upon the developmental experiences I described, we could assume that when we do that with a client, it stirs up a whole range of complex emotions about the current attachment opportunity, normally with a strong positive flavor if we can communicate a desire to help. But also, that's going to harken back to all the experiences and feelings the person has had in the past, also about opening up, whether that was safe, whether it was acceptable, whether they felt fear when they did that in the past. So then when they've had adverse experiences and developed an internal working model, which is more punitive and says you shouldn't open up about emotions, even though they get themselves to the therapy room and they sit with you, there can be a background punitive superego saying you shouldn't. So that's why we start to see unconscious anxiety manifesting in the room. We see anxiety showing up in the room when we reach to the person to say, open up, tell us about your difficulties. With the resistant person, typically this is involuntary muscles, striated tension, most commonly seen with hand tension, and sighing respiration. With people who also have access to repressive mechanisms, we also see involuntary muscle anxiety, primarily in the form of smooth muscles. That's all of the organs in the body. So we'll see anxiety going into those formats too, and we'll talk about those more over the course of the course. But a person being in conflict then between wanting to open up but feeling like they shouldn't, anxiety showing up, this is where we then expect to see defenses showing up in the room with us. This isn't a bad thing. If the person has defenses in their life, and this is part of what maintains the difficulties they have, the sooner we can learn about them in the room and we can see them, the sooner the person brings them into the therapeutic encounter, the sooner we can start to understand them and we can talk to them about it. So in ISTDP, rather than trying to sidestep resistance or move away from it, if that's part of a person's character structure, then we want it to come into the room so we can help them with it. There's just a prompt in the chat if everybody can ensure that they've muted their microphone, please. So what are the key ingredients of change in ISTDP that we're going to be tracking? One of Dr. Habib Davanloo, the founder of ISTDP, one of his key observations when he was practicing brief dynamic therapy and he increasingly became more and more active in therapy was that what he found is that as he started to be more innovative in his attempts to reach to the patient, to challenge defenses, to be more explicit about the importance of them being able to open up and to not shut down inadvertently, that he saw that the patients start to have feelings towards him. They were having reactions and emotional reactions towards him. And typically these had a simultaneous component of positive feelings, strong appreciation towards him, but also irritation and anger towards him. It was a mix. And at first, from the way he described it when I was able to see him talk, he described being surprised and shocked. What do I do with this? He understood transference and countertransference, but what should I do with this? And he started to actually invite the person to talk about those feelings, to talk about the feelings they were having towards them and actually feel them. And what he observed that it was the actual experiencing of these complex feelings, complex because they were being triggered by the therapist. But what he suggested is they weren't necessarily about the therapist. They were about past attachment experiences, which the therapist was becoming the lightning rod for, based upon their efforts to attach to them. And it was the actual experiencing of these feelings themselves, which became a type of triggering mechanism to lead to greater insights and openness in the therapy room. And this is what he labeled the unconscious component of the therapeutic alliance. So it's the unconscious in that the person is less overtly aware of certain insights. They're inside of the person, but they come at very specific times. They come as rise in complex feelings are mobilized to a greater degree. So then put these together, and then the mechanisms of change become in ISTDP, looking to help a person experience these complex feelings in the therapy room based upon our efforts to attach to the person. And the higher these feelings can come up and the more they can be looked at and felt, the more of this unconscious healing force is going to be there. And then the patient is going to communicate to us through these unconscious therapeutic alliance what the important issues are in therapy. They're going to bring content about specific life events. They're going to show understanding around their defenses. And this is going to help the process move forward. So this is a graphic representation then of the process of change in the standard format of ISTDP. On the left-hand side here, we have these two twin factors. Complex transference feelings as one variable, unconscious therapeutic alliance as a second variable. And we see this principle of as rise gets higher from low, mid to high to actual breakthroughs of the unconscious, proportionally we see greater degrees of the unconscious therapeutic alliance, which come in these different formats. The standard format of ISTDP and our hypotheses in ISTDP theory is that through intervention response sequences, if we track rise in complex feelings, which will occur based upon different intervention sequences, we see resistance coming up, we see feelings coming up, and we see alliances coming up. And as we proceed through these sequences using these different types of interventions, resistances will gradually get less, and we'll start to see greater access to the unconscious or the key meaningful memories and events about a person's life that typically make them so anxious and they shut down from. So how do we get started in therapy? Where do we start from? For those of you who are newer to dynamic therapy, then you'll have seen the lecture. I sent a lecture out for more basic principles in dynamic therapy. For people who weren't students, I didn't send this to you, but if you want it, you can back channel me. But this is a reminder that when we're looking to find a focus and ask about feelings, to talk about defenses, to be able to explore unconscious anxiety, we need to have an attachment focus. A good way of doing that is developing what I call an attachment theme, where you start to listen for themes around a person's wants and needs, relational needs in their life, in relationships, perhaps at times where they become symptomatic. So seeing relational experiences as potentially precipitating events, sift out and inquire how they hope to be treated in relation to connecting to others, and then ask them about how they actually expect people are going to treat them, though, or actually how people do treat them. And when you can start to elicit multiple examples of this, what you start to see then is often a theme around people having negative expectations about attachment, wants, and needs. And this becomes the context then where you can start to invite people to say, so should we look at the feelings you have about wanting to be connected to your spouse, but experiencing repeated rejection? Let's look at how you feel towards your spouse. This becomes a context for that. So we're going to go to a tape and look at how this process starts to roll out. We're going to think about when the person comes in. When they come in from the start, sometimes patients come in mobilized. They come in already with feelings on the front. They come in with key conflicts they want to address. Other times they don't. And in that case, we'll inquire about their presenting problem, and we'll start to do what we call pressure in ISTDP terms, or encouragement for them to tell us about their problems and to open up. And we look to see how the patient responds to help us think about how helpful the process is actually going to be. So the principle here is inquiry and pressure. So what is pressure? Well, pressure, the broad objective of pressure is to mobilize these twin factors. We want to mobilize those because they're part of our ingredients to change. In Davenlou's early texts, these are some examples taken from those around forms of pressure. So these are akin to most psychotherapy models. You would do similar things. You'd ask for what are the difficulties you come with. Ask for specific examples. As a dynamic therapist, or maybe just a more intuitive, broader therapist of other stripes and colors who sees smoke screens when they're there, if a person's implying something's there, but they're staying away from it, you might make explicit that and you'd ask them about it. So these are some examples which you can look at, which represent forms of pressure, and we'll identify further ones in the tapes. More broadly, when to help you think about what we mean by pressure, then, we're wanting to establish a dynamic line of inquiry, a focus around attachment relationships. It isn't one single intervention. It is, though, however, a systematic approach to encouraging a person to be as honest and as open with you as they possibly can. And I think if I look at my training in ISTDP over the last 20 years, if I was to boil it down, that would be one thing I would say has really impacted how I view how I approach when I sit with a person for the first time. I'm trying to communicate to them, let's have an open, honest conversation as two people. That's going to be helpful to you, I think, and convey that. If you can do that in your own way, in my experience, that will mobilize complex feelings in people who've had negative life events and poor attachment relationships at some point in their life. It'll trigger a lot of feelings inside of them. Then we can start to see anxiety about feelings, and we can start to see defenses about feelings.